Here is a case of supine PCNL for failed RIRS case. Even though stone is very small, RIRS could not do the job because of the angle, because of the inability to reach the laser fiber, the stone. 21 years old female patient with right loin pain on and off 2 years, bilateral renal caniculi, right side 9/6 was there, left side 7/9 was there. Initially we thought it is a small stone, but inferior calyceal stone, option of supine PCNL as well as the RIRS has been kept. IBP is not available, we cannot assess the angle. Routinely we proceeded with RIRS, but keeping in mind we kept in supine PCNL position. The idea of sharing this video is combined access position is nothing but supine PCNL position, and we went inside with access sheath. It was not pre-stented. Luckily access sheath has gone, and the inferior calyx is very deep. Some amount of polyps were there, a little bit of blood was there. This is the angle. In this angle we tried to break it. After breaking half stone, rest of the stone is not able to break because laser fiber is coming at the 9 o'clock position. We did not have a scope, anything which laser fiber comes at 3 o'clock position. So much time we tried and tried, but it did not succeed in moving the stone. We tried basket, we tried little bit lasing, we tried thulium fiber laser with high energy frequency, nothing worked. Ultimately we realized that the volume is more. See, here we are tying with N circle, taking risk even because infundibulum was okay. In fact, we have released a little bit of infundibulum on the medial side, nothing worked out. So then because already position was there is no need to change the position. PCNL is like any other PCNL. Immediately guide wire has gone. Once you went inside, you came back from the pelvis and you had an acute angle. But for PCNL that angle is not a problem. We came back initially, and last we got when severely attached to the mucosa on the lateral medial aspect of the calyx. After that we pulverized that because it is a ultra mini perc. We did not have choice to break with pneumatic lithotripter. We spent around 15 minutes of time, and standard laser lithotripsy micro fragments or dust is done so that they are evacuated during the surgery itself, and complete clearance is achieved. To conclude, inferior calyceal stone, if the laser fiber is at 9 o'clock, if the stone is impacted deeply at 3 o'clock, it may be difficult to reach, especially if the infundibulum does not have space. Especially if passive movement of the flexible scope fails. Most of the times passive movement of the flexible scope helps to get the stone away, but in this case nothing helped except we realized that if we continue the scope may get damaged, so you should know when to abandon. There is nothing wrong doing mini perc or a perc in this case and removing the stone. Ultimately patient expects safe removal of the stone. So now we have put the stent. We did not put the nephrostomy because it was very small hole. This sheath is 11.5 access sheath, and after that patient did well post operatively. Thank you.